So this is the study that shows that your response to triptans is better if you take the higher dose. The higher the dose, the more likely you're going to be pain-free. And this is one that shows that the higher the dose, the more likely your headache's going to come back. So that sounds like a prescription for a medication overuse headache if I've ever heard one. Basically, you take as much as you possibly can. It's going to leave you pain-free as much as possible, but it's more likely your headaches are going to come back. So, and that's what these patients are sort of going through, and it sort of fosters this addiction to medication taking, particularly in those when it's with the chronic sufferers for whom it's not really working. Medication overuse headache is a huge bane of, I think, our existence. I mean, it's really hard because these patients are addicted to these medications, and they're not addicted in such a way that they, they're getting secondary gain by taking them. It's not euphoria or anything else, but it's like, by God, I've got a headache. I have no hope right this second. If I take this pill, even if it's not going to work, I have maybe some hope that maybe sometimes it'll work. So you get into this habit, and so if there's ever a headache, that comes on, you feel like if you don't take something, then it's like shooting yourself in the foot. So these medications, I mean, I've had a patient recently that came in that took Anacin. She took 12 Anacin every day. And I don't know whether it's her migraine pain or Anacin, and so I try to get her off that medication by giving her, a brief stint of narcotic plus the Botox and a talking, and we say we're not saying that you're an addict, you're just addicted to wanting to be pain-free, and who wouldn't be? So it's interesting, Debbie, you said that you guys have going to the surgery with plans for the weaning afterwards. That's really interesting because prior to that, every time we've had 2 surgical symposium in Cleveland over the past 2 years that Dr. Guyron and Dr. Reed have put on, along with Dr. Kriegler, and now an ENT surgeon that works there at the University Hospital. But and we've trained 50 new surgeons each of the last 2 years, and there's another one this year. But each time I've gone, we've talked about the fact that medication overuse headache, don't forget about it because it's not going to work if you do the surgery, because there's some sort of exciting or leaky membrane or some problem that those medications cause, and they will cause your migraine threshold to be low no matter what these triggers are doing. So Botox and migraines has been used for years for cosmetics. Since the mid-'80s, Dr. Guyron has been using it because they were using it in children for blepharospasm, and also for muscle spasticity in the limbs. And now it's FDA approved for cosmetic use. It is injected more than any other medication, I think, in the country. I'm pretty sure. Certainly, as far as cosmetic procedures, it's the #1 procedure. And to date, there's still been no systemic ill effects from cosmetic Botox. You've heard about a few deaths lately that they've got out in the literature, and I think it's the wrinkle filler lobby that's getting that in the literature because those compete. But the Botox deaths that they've had have been in kids that have gotten like 600 units. And I've never injected more than 100 units, and that's only been in a significant migraine patient, and I don't inject that much anymore. I only inject generally more than 80. So, and that's what a lot of cosmetic patients are getting, 16, 80 units of Botox all the time, without any reported systemic ill effects of that. So I think Botox is a very safe medication. I think it is a toxin, but and you can spin that however you want. There have been reports of Botox working in the literature for years, little snippets here and there in different types of literature. They did do a study looking at Botox and comparing it to placebos, and it was no offense, but it was put on by neurologists. And when they injected the Botox as a bandana all the way around the head. Or what was their other way? The follow the pain. Oh, it hurts here? Okay, I'll inject there. Absolutely no regard to the underlying anatomy, to where the nerves were, to where the muscles are, and where the nerves are exiting through those muscles. I presume the theory was that if you injected it under the scalp, that it somehow leaked into the brain, right? I mean, isn't that what they're thinking? We've sort of already talked about some of this. Basically, it all began with cosmetic Botox and people getting relief with their headaches, and then also the surgical version of brow Botox is a brow lift, and those patients were also coming back saying, I haven't had a headache in 2 years and I like my brow. And Dr. Guyron heard that enough to where he finally did a retrospective study, small retrospective study, 31 patients, and they were all IHS, met IHS criteria for migraine headaches, and they had a significant improvement after their brow lift, but this is all retrospective. Subsequent to that, they looked at Botox, and people that responded to Botox did far better surgically than those that didn't respond to Botox, which sort of established Botox as a predictor or prognosticator of surgical success. And primarily because Botox lasts about 3 months. It interrupts the communication between the nerve and the muscle, so the muscle gets kind of weak, and that Botox falls off after about 3 months' time. And they were curiously finding that people's headaches would get better for 6 to 12 weeks after a Botox injection, which is exactly the period of time that Botox works on muscle. So naturally, we think that the Botox is having its effect on the muscle. There may be some effects in the nerve that have shown that it does go down the axon, I believe, but in terms of what it does, no one really knows, or if it does anything inside the brain. Finally, the prospective randomized trial comparing 4 zones of surgical treatment is a paper I'll get to called Comprehensive Treatment of Migraine Headaches, and it was quite an impressive study. And then this last one here is the placebo sham surgery, which is now finished and up for publication. It's been presented to JAMA, and they turned it down. It's now being presented to Headache, and it's remarkable data. We've talked about this. The temporalis impinging on the zygomatic-temporal branch of the trigeminal nerve, which is a tiny little nerve right here. It's a nerve that when cosmetic surgeons do brow lifts, they cut it all the time. I mean, it's like the size of a hair, and it's the sensory distribution you can't even really find. But in migraine patients, it's quite an important nerve, and that's the only nerve that we remove. People think, oh gosh, you remove these nerves. But this particular nerve, that is done, but it's something that is, I'm sure a lot of cosmetic surgeons don't even know its name, or they're not even sure it's a nerve, really, when they go by it. The occipital semispinalis capitis impinging on the greater occipital nerve, that's a pretty big nerve back there. It does a lot of sensation to the back of the scalp, and that nerve is preserved, and I haven't had a single person come back and say they have permanent numbness in the back of their head. The nasal septum and turbinate complex, it's generally people have airway breathing problems. It's a common operation for deviated septum and for sinusitis. That's the 4th site. The first, which is not up there, is the supraorbital supratrochlear nerves, which come right through the frowning muscle, which is where the whole brow lift thing comes in. This is a comprehensive surgical treatment of migraine headaches. Came out in January of 2005, plastic reconstructive surgery, and basically showed 82 out of 89 patients had at least 50% reduction in severity, duration, or frequency. 31 out of the 82 patients had complete elimination of headaches with a follow-up of just over a year. And now you have what? Don't you have 4-year data on these people? 5-year data. And what kind of recurrence rates do you have? Because I didn't have that. Really no recurrence rates. So it seems to be working pretty permanently, as long as if you think 5 years is permanent, which I do. So we look at, and it showed, and these are some important things. Average days lost from work per month went from 4.4 to 1.2, and the controls went from 6.2 to 4.4, and then the annualized cost of treatment went from $7,600 pre-treatment, dropped to $925 the year following treatment. And why Anthem of Maine doesn't jump right on that, I don't know, because they certainly have in Ohio and they have in Kansas as well.